Good afternoon, everybody. I'd like to welcome you on behalf of the School of Public Health and Preventive Medicine to this seminar today, which is going to look at right across at the terrific cardiac registries that exist in Victoria at the moment and provide a wonderful data source, which I think is quite unrivalled in most other places. We've got a great series of speakers today. Who'll start off with a discussion of neonatal heart surgery with Yves and Karen Duplessis, who've been running that registry through the Children's. Then Karen Smith is going to talk about the cardiac arrest registry, which I'm assured is the best in the world. Then VCOR, Jeff Lefkovits is going to be presenting in a registry which he and Chris Reid and Angela Brennan have been working up over some years. And then finally we're also going to hear about the Victorian Cardiac Surgery Registry where Gilbert is going to talk to us. I think the purpose of this afternoon is to showcase just what an amazing resource we've got and how it can be, how it's developed, the problems which we've run into, the problems which we've solved. And increasingly, I think we hope to be able to make it bigger and better and interact more and so on. So we'll also be exploring some of those possibilities. So without ado, I'm going to ask Chris Reid. Chris has been a professor in epidemiology and preventive medicine for what must be 15 years, Chris, I think, and recently took up a position, chair of Curtin University, but has still retained his position. And it's really under Chris's leadership and guidance that a lot of the work at Monash, at least, has developed. So, Chris.
Terrific. Thanks very much, John. It's great to see so many people here on a pretty wet Melbourne afternoon. And talking about something which has really been a very, very important part of our work over the last decade, or actually the last 2 decades. And I think it's pretty fair to say that where we sit now, there is an enormous interest, really right around the world, in terms of cardiac registries, and that's really accumulated. Not only with the in the early years with the Society for Thoracic Surgeons in the US, who have developed up a massive cardiac surgery database. Similar activities have been done by the Society of Cardiothoracic Surgery in Great Britain and Ireland. This has been matched and has been extended by groupings of cardiac registries, particularly in the US with the National Cardiac Disease Registries, and clearly across Europe with the best example there has been really the Sweetheart Registry, where there's been an enormous amount of work from government agencies, from clinicians, demonstrating that the development of these cardiac registries not only can focus on improving patient quality, but they've actually been able to demonstrate impact on the economic value of providing cardiac care in those communities. But the important thing over the last 20 years is what was the major impetus? Well, certainly for us here in the cardiac surgery area, the major interest started about 20 years ago when there was, and many will remember, the inquiry into paediatric cardiac surgery in Bristol, and the demonstration of perhaps improvements being required. And what that led us to do in Victoria, and this is going back into 1999, was to do a demonstration project looking at 5 existing hospitals, public hospitals undertaking cardiac surgery, and just bring their data together and look to see what we could actually find. And this is a very, very important slide, because what it actually showed us, that yes, hospitals were collecting data individually, but by bringing it together, we made one fundamental mistake, was that we had very different data definitions. And so we had one of our hospitals in this report, where we looked at risk-adjusted post-operative hemorrhage, was way out as an outlier. And in fact, that graph is cut off at 10%. It actually went well beyond that. And that was a really important lesson to us back in the late 90s, that if we were going to do this and do this properly, we actually needed to have a very systematic approach to how we collected that information, and more importantly, how we defined that information. So as cardiac registries have developed, really the need for standards has become really a byline in terms of all of the registries that we're doing. And most of our data, or most of our registries now, come with very clear and defined data definitions. What's important here is that these definitions are then being fed up through into standards applied across Australia as a whole. And so we've worked with authorities, the National Data Dictionary, to ensure that where we're collecting information on a registry basis to use to inform on the quality of care, that we're able to ensure that we're collecting and we're reporting on the same thing. Whilst it seems very fundamental, this, I think, is going to become one of the more important areas that we need to focus on, particularly when we touch on the role or the potential role of the electronic health record, and how we might be able to use that to facilitate our data collection for registries. So registries have clearly developed in the area of data, and John his heart will warm when he sees this one about the concept of the registry actually providing the spine of data. And that's the balance, and talking with Ingrid just before, the balance between collecting sufficient information in any of our registries that provide us with key information on who's having surgery or who's having whatever type of a procedure or intervention or management. What are they actually having, what's been done, and what are the outcomes? But clinicians importantly want to know everything about their individual patients, but from a registry's perspective, we need to be very, very clear and precise on the key information that we need to address the questions that we're trying to answer. And so the focus on minimal information, on being objectively collected, and certainly that concept of all or none, and that's something we've worked hard in Victoria to really try to ensure that when we do embark on our cardiac registry data collection, that we have an all-comers approach, so that all cases are being collected, and that's a very fundamental area in registries development. We've also come a long way in the way in which we collect data. Obviously, we've moved, and there has been move away from forms-based collection through to online, web-based electronic case record collection in very highly secure ISO standard environments. And these are important steps, because these are very, very important issues in relation to governance and data and how data is managed. And I'll touch just a little bit later on where I see we're going, or where I think, and I hope, we are going in this area of data collection. It needs to be facilitated to be efficient, and whether we can use existing information that may be collected through routine sources to help populate our data register or our cardiac registries. I think we still need to do a lot of work in that space. But I think we're going to have to look at that as opportunities for improvement and advancement in the future. But we certainly have now, I think, the capabilities to ensure to stakeholders that data that is collected in these multi-institutional registries is collected in the very highest security standards, and I think that is a key asset for our registries. I think the other area that has developed over the last 20 years with Victoria's engagement in the cardiac registries has been the area of governance. And I'm sorry about that, it's governance. And governance means lots of things to different people. It can be ethics, communication, peer review is a very important component. Stakeholder management, how do we engage quality insurance, making sure that we are very sure about the reports that we're providing on hospitals and how we're able to look at inter-hospital comparisons. Consenting issues, privacy, ownership and access to data. They're all really important components of governance, and I think the last 20 years has seen advances and quite sophisticated advances in how we approach these important governance issues. And again, what they tend to do is give people, clinicians and stakeholders, the confidence in the implementation of registries, knowing that issues of governance are being addressed, are being considered and are being taken into account in the development of these registries. One of the important developments in the last couple of years in governance has been in the area of ethics and the concept of opt-out consent or opt-off consent for ethical approval to collect data to inform on clinical quality. That's been, and certainly led by John and the Monash group, really have influenced thinking. And this is now a part of NHMRC ethics documentation that opt-off approvals can be gained, and that certainly facilitated the adoption of registries in a number of areas, and in particular in our cardiac area. The other development area for cardiac registries has been in reporting, and I think this is one where certainly Monash has had an important role in looking at, what is the best way of reporting this information, because there are multiple ways to look at what we're doing. Control charts, cumulative sum plots, VLADs, variable life adjusted displays, and funnel plots are variations on methods that we can use to look at variation in performance and to look at outliers. But when we do report, we need the consideration of issues of peer review. When we do find or we do identify an outlier, what is that peer review process that will be acceptable to stakeholders and clinicians and the public? What about public availability? And I'll touch a little bit on that in terms of access to information on the quality of service provision within state-funded and private hospital institutions. That's a very important area that we have seen development, and I think we're going to see further development over the forthcoming 5 to 10 years in this whole area of public availability. And the concept of how do we present that information to inform rather than to penalise, and the concept of league tables is something that we've been really working hard in terms of how best we can deliver information on performance. This is just from a recent, and there are multiple examples in the literature, but when you look at the concept of ranking performance, the fundamental flaw is in the variation, and you can see very clearly in this presentation or in this slide, either whether it be crude mortality or risk-adjusted mortality from cardiothoracic surgery in the Netherlands, the confidence intervals over those point estimates of mortality rate are very wide. And the reality is that very few of these hospitals actually differ. But if you're number 1 or you're number 12, that's a problem. Nobody wants to be at the bottom of the queue, but the differences are very, very minor, and they vary. They can vary from quarter to quarter. So we are working hard to look at what are the best ways of reporting information back to stakeholders, to the public, on performance. And we certainly we don't think the ranking's the way to go, but we have to come up with better methods. And methods that we are currently using, and you'll see in the reports that are available for you today. So that's what's been happening sort of developmentally as we've come through to where we are in Victoria with cardiac registries. Undoubtedly, the Society of Cardiothoracic Surgery's registry was initiated in Victoria, and Shardey will be talking about that. We were involved with the Commission for Safety and Quality in Health of looking at evaluating clinical quality registries, and the registries group at Monash were primary authors of the operating principles and standards for clinical quality registries, which now have been approved by the Health Ministers Advisory Committee and are adopted as standards for developing clinical quality registries in Australia. And they've been really important because they've underpinned and helped shape the development of VCOR, which you will hear more about today. And they've actually been very important because those principles have helped other jurisdictions in Queensland, in South Australia, really feeding off the work that's been done in Victoria and utilising those operating principles to bring together the concept of cardiac registry and cardiac evaluation across Australia. And there are some initiatives looking at how potentially in the future we may be able to report nationally. And we certainly think that the concept of a federation of states is a good one in the basis of registries, because clearly what we've certainly seen is it's that local involvement, that local engagement and that local stakeholder buy-in that's been fundamental to the establishment of these cardiac registries in Victoria. So where do we see the future challenges? And I'll just finish off touching on the future challenges. Clearly data. Big data in health is a catch cry that I'm sure you've heard, and we're going to hear more of. And certainly initiatives in the United States around the PCORI institutes, which is trying to utilise big data held in insurance organisations such as Kaiser Permanente, in large Medicare repositories. I think one of our biggest challenges in the future is going to be to be able to use this big data in a way which we can A, make sense of, and B, interpret in terms of the quality of the care that's provided. Registries are going to be a very important part of that big data, and I think what we probably need to look forward to is how can we be sure of those fundamental issues of data definition and data quality when we're using large data sets or data collected through other sources. And we'll see there are opportunities opening up in Victoria now in terms of data linkage and the opportunity to utilise outcome data collected through major hospital systems, whether they be government or private, and utilising registries, linking with large data sets to be able to give us a better picture of clinical outcomes for patients undergoing these cardiac procedures, certainly in Victoria. So I think that's going to be one of our big challenges, and there are some exciting initiatives that are going forward in the area of data linkage with the cardiac registries that hopefully we may hear about. The other area, and I did touch upon it earlier, it will be in public reporting, and certainly the National Cardiac Disease Registry in the United States is focusing on the concept of voluntary hospital public reporting, and they've put together really a mission statement, and at the moment this is a voluntary initiative. It's being done by a number of the cardiac registries, which is asking hospitals to voluntarily report their outcomes and being identified as hospitals contributing to these registries. And as I say, it's voluntary at the moment. It's certainly part of the NCDR is the cardiac surgical registry, and you can just jump online and look at the STS database and at the public reporting of individual hospitals and groups of surgical specialists are identified and reported in a star rating of care and quality of service provision. And we're certainly very interested on looking at developing some of these composite and key performance indicators that may be very useful as a mechanism through which public reporting could be advanced potentially here in the state of Victoria. I think this is clearly something that's very important to discuss. It's very important for a lot of thought and consideration to be put into it. But this is a terrific example of where I think we're going clearly in the cardiac area in terms of ensuring that we're reporting on the right measures and giving those right indicators in relation to into the quality of cardiac care. So I think we're going to see a lot more of this in terms of future developments in registries. The other challenges in relation to registries certainly will almost be one of containment, and I've got a following slide which will say that there are probably 20 different cardiac registries being developed up in the NCDR program, and we can see potentially similar initiatives here in Australia. Registries are going to fit very firmly at the centre of the cycle, of the quality cycle, in terms of providing clinical evidence, looking at guidelines and guidelines information, identifying those appropriate performance indicators, that critical measurement and feedback. And there are some good initiatives that are being done, supported by the Heart Foundation here in Victoria, on feedback mechanisms for improving quality of care. And the area of outcomes and how registries can inform on outcomes. And clearly, I think the other big challenge is going to be in the area of patient-reported outcomes. You'll see, I believe, in one of Gil's slides, that the registries collect and report on outcomes pretty well, but we do have a gap at the moment. But I think there's still some uncertainties about what are the right outcomes we should be reporting in terms of patient perspective. And there is a number of alternatives. There are a number of research initiatives being undertaken at the moment, utilising feedback and input from patients on what are the most important outcomes from their perspective. And I think when we get the blend of clinical outcomes, patient-reported outcomes, and then stakeholder outcomes, I think we're going to have a really important consideration of what does define good quality care. So just finally, the future challenges, you can see this is the NCDR registries, the actual plethora of different cardiac registries that are underway in the USA, and similarly in the European registries. All aspects of cardiac care lend themselves to actually be the focus of registry work. High cost, high risk and high volume. When you have those three considerations in terms of the care that's being provided, then we need to know that what we're doing is of good quality. And I'm really looking forward to the rest of the afternoon to hear on the initiatives that are being done here in Victoria. So I'm going to stop there. Thanks for your attention, and I think we can, happy to take any questions, or we can move straight on to our next speaker. Okay. The next speaker is Professor Lefkovits. Jeff is an interventional cardiologist and director of the Cardiac Cath Lab at the Royal Melbourne Hospital. And importantly, he's the clinical lead for the Victorian Cardiac Outcomes Registry, which is a statewide clinical quality registry focusing on performance assessment and benchmarking the safety and effectiveness of cardiac procedures and treatments, and particularly PCI. And I think with no further ado, I'll ask Jeff to give us an update on VCOR. Thanks, Jeff.
Thank you very much, Chris, and thank you for inviting me to speak this afternoon on the Victorian Cardiac Outcomes Registry. And by way of introduction, VCOR, as a clinical quality registry, is really focused on improving clinical practice. And so I thought that would start off by giving what really is the clinician's view of the health regulatory landscape that we're facing and the complex natures that we see. As clinicians, we realize that our target is the high quality cardiovascular health care. And that really is informed by both national policy and implementation at a state level. And as I go through this, we'll see the kind of things that clinicians are facing. Firstly, we have guidelines for practice put out in the case of cardiology by the Cardiac Society and the National Heart Foundation. We face accreditation, but more personally, clinical standards on how to practice put out by the Commission for Safety and Quality in Healthcare. Our registration is looked after by APRA. Our hospitals are looked after by the National Health Performance Authority. And of course, we are subject to statistical analysis by the Australian Institute for Health and Welfare. From a state level, both the government and the Department of Health are important, both policy formation and in implementation. The health services clearly have a key role, and now the clinical networks are playing more and more of a role. And on top of that now, even we've got on top there, Medicare is now looking, in their review of the MBS items, is now looking at introducing appropriateness criteria into day-to-day practice of our procedures and our treatments. And so it gives us a focus as clinicians that there are a number of expectations on us in terms of clinical care, and also that it's incumbent on us to measure our performance. So looking at VCOR here, looking at the timeline from concept to creation, in about 2008, the Victorian Department of Health put out a health priorities framework, and a number of recommendations were included in that document, one being the formation of clinical networks, in particular cardiac clinical network for us. And secondly, it was an enhancing, that there should be an enhanced role for registries in part of quality assurance activities. In about a year or so later, the Cardiac Clinical Network was established, and our group also performed a pilot registry, basically a proof of concept to show the feasibility of looking at procedural registries. And then it was a couple of years later that John McNeil, was able to secure funding both from Medibank Private and from the Department of Health, and therefore VCOR was created in about 2012. We now are I would say, maturing as a registry. This is our picture of our annual report released just a couple of weeks ago. We now, in our PCI module, can proudly say that we've engaged all public and all private hospitals in Victoria in terms of participation in VCOR. We now have over 28,000 records in our registry. We are providing risk-adjusted outcomes, and we have also looked at extending our interest beyond PCI to a non-metropolitan, rural-based, looking at the early management of heart attack, or STEMI, in a rural setting, and have also now recently added another module looking at decompensated heart failure and its acute management in the hospital setting. And the life cycle here, and this is just an example, I don't really want to go through every single one, but basically it's a complex process setting up a clinical quality registry. And here from the beginning in 2013, when we started off with site engagements, we have actually been through each one of these steps, through site training, through data collection, to quality assurance, and then getting over here now towards the reporting, and to the point now that we are basically here in 2016, we've almost come the full circle, and we're now at the point of not only coming up with regular reporting, but looking at research and publications. The signature outcome for our registry is the 30-day risk-adjusted mortality. And as Chris has shown, there are a number of ways in which these data can be presented, but we find this the most useful, the use of the funnel plot. And we can see there that the curvy lines there represent 2 and 3 standard deviations. And here are all the hospitals participating in VCOR plotted in terms of their case numbers and their risk-adjusted mortality. And we can proudly say that in 2015, all hospitals, both public and private, participating in VCOR had risk-adjusted mortality that was within control limits. There were no outliers, and we now know that for a fact. And on top of that, that the average of risk-adjusted mortality across Victoria was 2.7%. But the talk here this afternoon is not really so much to highlight what the findings of the last annual report is, but it's more a focus on what impact on clinical practice has our registry had. And I'll just go ahead now with a few examples. The first here relates to our early experience in relation to hospital engagement, getting the hospitals to join in with us. And if you have a look here, 2013 to 2015, the bars on the left represent the public hospitals, and we were able to get virtually complete engagement from all public hospitals at a very early stage. The interest lies really in the private sector. And what we saw here early on was that the private sector was slow to engage, with 6 out of the possible 17 hospitals at the beginning. And then there was this rise a year later, and this related mostly to the participation of the health scope group of hospitals. And this is where the interesting story lies. At our initial startup meeting, probably the most vocal dissident in the room about starting up with VCOR was the CEO of HealthScope. And his argument at the time was that quality assurance activities were not the responsibility of the private hospital organisation. This should rather be left to the clinicians. The hospital itself should provide the bricks and the mortar and the equipment, but it was really the clinicians. And he was quite vocal and he was outspoken. But what happened that over a period of a year or 18 months, pressure was brought to bear on the HealthScope groups, particularly by Medibank Private. And in their pursuit of quality treatment and knowledge of of how their treatments that they're funding are actually going, they put pressure on the HealthScope groups to basically comply with quality assurance activities and join VCOR. And it was successful. They joined us, and in fact, the HealthScope hospitals now are one of our strongest contributors to our registry. If we look down at the end there, we still see that there's a group here of 3 hospitals, private hospitals, that have not yet joined. And I'm again pleased to say that in the last couple of months, again through efforts of John, that we've been negotiating with the Ramsay group of hospitals who represent those last 3 hospitals, and they now too have agreed to join VCOR here in Victoria, to the point that we can proudly say that all hospitals performing PCI in Victoria are now included in VCOR. Another issue around the effect on clinical practice is the idea of data collection and the quality assurance activities becoming part of the day-to-day running of hospital departments. And again, the private sector has been able to, through their resources, been able to hire additional staffing, additional data managers to collect the data. But the public hospital, the public sector, has been harder because of more financial constraints. And here is one example of an innovative approach by one of our public hospitals that has thought to divide the data collection activities into smaller chunks. And they've allocated different parts here on the left here, different parts of the data case report form to various team members or staff members along the way. The radiographer, the cath lab registrar, the ward registrar, the cath lab nurse. Each one of these staff members has a relatively small responsibility, so it's not too onerous, but it becomes part of their day-to-day activity. And this innovative approach has proven very successful for this one particular hospital. Again, showing that innovation can certainly be effective. VCOR also has the ability to plot changes in practice across time. And this is just one example of that, where performing angioplasty via the radial artery through the artery here in the wrist has a number of advantages, both in terms of safety, patient comfort, and in outcomes. And there's a general trend internationally to favour this radial approach over the traditional groin or femoral approach. And what VCOR has been able to show is a trend across time. And here we look at both the division between the public and the private sectors. The public sector has virtually adopted it to 50% at the moment, whereas in the private sector it's a bit slower. Only about 1/3 of cases are done via the radial approach. Now, the reasons for this remain somewhat uncertain. It's hard to say, but what showing these data back to the hospitals does is it allows the hospitals to know where they are on the spectrum. It prompts them that there are other ways of improving practice, and just keeps the whole issue alive in people's minds to follow and track. In addition to our regular and routine reporting, both on a quarterly and an annual basis, we have from time to time done what we've called special reports. And here's an example of a special report we did early this year, looking at what we called a deep dive into angioplasty for a heart attack or for STEMI. And the background to this was that as we looked across the board at the performance of all the hospitals as part of our registry, there is a time-critical measurement from the time the patient walks into the hospital until the patient receives his treatment, what we call the door-to-balloon time, which in international guidelines suggest that should be done in less than 90 minutes. So we have a look here across the board at the proportion of cases that are done in less than 90 minutes. And most, but not all, but most hospitals fall below the accepted benchmark of 75%. And with this somewhat underperformance, we went ahead and tried to help the hospitals identify where there were issues that could be improved upon. And here's one of our analyses, for example, where we looked at the time taken from arrival to the hospital to arrival to the cath lab, that transfer time, and we divided it by whether the case or the patient arrived during hours or after hours. And the graph here shows these bars in pairs. The blue one and the grey one represent in and out of hours delays for all the various hospitals. And as you can clearly see, that hospitals take longer during after hours to get their patient from the front door to the cath lab. Some hospitals just 10 or 15 minutes. Some hospitals can take 40 or 50 minutes. This is clearly an area that can be improved upon. And obviously, and one other feature that we identified here was that not only were there outliers in a negative sense, but there were some outliers in terms of a positive sense. Some hospitals there where the time differences were hardly anything. And what we went ahead and did was we surveyed the good performing hospitals. So here we were trying to come out with a positive message and identified from these hospitals a number of factors which that seemed to promote this efficiency in their management of acute heart attack. And we've since, through the special report, have disseminated these positive outliers, the ones that are high performing, to the whole group in order to help generally lift the standard of the whole cohort. But probably for us the most powerful effect on improving clinical practice is what we've called here as the power of the red dot. And here's an example of results of a performance indicator from our 2014 report looking at in-hospital major bleeding. And as everyone can see, there's one hospital there, the red dot, that is lying well outside 3 standard deviations. This hospital was an outlier in terms of its bleeding rates. And in true form with our registry, what we do next is that we inform the hospital that they are an outlier and offer our assistance in trying to help them determine what the causes might be and how they may go ahead and improve it. So what this hospital did, not really with our assistance at all, they did it by themselves. They went ahead and did their own site internal audit of their bleeding cases. And here's just a sampling of what they did. And they looked at the various cases, and you can see the ticks are where they agreed that there was a major bleeding event, but there are a number of crosses where there actually was miscoding. For example, if you look here at this one here, a 91-year-old male, there's actually an error in there's actually an error in the way his hemoglobin drop was calculated. In fact, it wasn't a major bleeding event. The next one down was called a major bleeding event because the CT scan showed a brain hemorrhage after angioplasty. But that was when the data manager reported the case as a major bleed. But in fact, a day or two later, the patient had an MRI scan which showed no evidence of bleed, and therefore it really wasn't a case of major bleeding. When these cases were recoded, that hospital that was an outlier initially was no longer an outlier. It came back into the group. So in fact, that hospital knew what its bleeding rates were, understood that there were some errors in its data collection, and has highlighted to that hospital, particularly and to the group in general, how potential outlying episodes can be handled. What about future opportunities? Well, we are seriously looking at adding an additional module for implantable defibrillators. This is one of the high-cost devices that Chris was talking about earlier that is used to help both treat and prevent sudden cardiac death in vulnerable patients. They are expensive items, up to $50,000 per device, and there are issues in terms of whether these devices are being inserted for appropriate criteria. There are issues in relation to both the performance of the device and of the lead, the wire that's used, the leads that are used, and also procedural and long-term outcomes. And we believe that this lends itself to taking part in a clinical quality registry, which we are looking to expand in VCOR. And it is fair to say that there is nothing like this in Victoria at the moment, or perhaps anywhere else in Australia. Another important, exciting opportunity for us is, as again Chris mentioned earlier, was the concept of data linkage. And we have been in discussions with both Ambulance Victoria and with the Department of Health through their data linkage unit to sharing and collaborating our data with theirs. particularly Ambulance Victoria. We hope to and are very close to establish a regular exchange, a two-way exchange of data that they can use for their own data analyses, and so we can use for ours. The VAED as a body with administrative set of data has a number of potential opportunities for us. And here is just one example of some work done by one of our collaborators, Vijaya Sunarajan from the University of Melbourne. She was able to get nearly 130,000 records of patients with AMI over a 10-year period, looking specifically here at the rates of angiography and revascularization. And what she was able to show here that perhaps most notably here in this group down here for the non-ST elevation myocardial infarction, nearly half the patients in Victoria over a 10-year period did not receive angiography or revascularization as a result of their subsequent to their AMI. So what we are seeing here that there are trends where big data can give us a lot of information in terms of trend, and we can see a lot of synergy between data sets like this and our pursuits in terms of a continuous quality improvement. There have also been a number of documents and work done in recent times that fit in nicely with what VCOR does. You know, from a federal level, the Commission for Safety and Quality in Healthcare has recently released the acute coronary syndrome clinical standard. This document provides 6 quality statements of how people should be treated and allows clinicians, hospitals and other stakeholders to actually be measured in terms of their performance and whether they comply with these statements, and again offers synergies with what we're doing. Again, from a federal level, the Medicare is going through its MBS review and is adding, we hear that they're adding terms related to appropriateness in terms of our procedures, and again it would be incumbent on a body like us, on an organisation like us, to try and follow along those appropriateness criteria to see that that people are doing what they're supposed to do and what have been set out by bodies like Medicare. And finally, we're eagerly awaiting the Duckett the Duckett review on hospital safety and quality assurance in Victoria. And although I hear that it's just about out, and looking at ongoing issues related to the provision of safe practice in Victoria, and again, we suspect that there'll be a heightened role for registries and quality assurance activities. So to conclude, I think VCOR represents a successful implementation of a multi-modular design as a clinical quality registry, and that we are now expecting 100% capture of PCI cases, that's 10,000 cases per year, within 4 years of commencement of the registry. And I hope I've been able to demonstrate that we have and hopefully will continue to have impact on quality assurance activities among hospitals in Victoria, and we remain well positioned for future developments in the registry and quality assurance fields. Thank you for your attention. Happy to answer the questions.
For Jeff.
Yes, hi.
I've just got a quick question. I'm interested in that the outlier that you highlighted, the red dot for the group, just in terms of the assistance that you were able to offer, the feedback mechanism, can you talk me through what that actually looks like?
So it depends. We have multiple different levels of feedback, and can start from a very informal level, just a casual say, look, because we do quarterly reports, we can see if people are starting to sort of deviate from being within control limits. And usually the next step would be that we would write a formal notification to the site, to the principal investigator, that you know you've been out of control, you've been outside of control limits for a certain period of time, and that we will certainly offer any assistance we can. The balance is that we are providing a service to the hospitals, and that we're trying to help them in providing the best quality of care. So we will do, it's not like they have to report to us or we're like policemen watching what they do. It's that we are a tool for them to use in their quality assurance activities, and then we provide any assistance that we can, which usually would be a list of the patients or a list of what the complications have been, or any other information in a sort of in a process form that they would find helpful. And in return, we ask but don't demand that if the hospitals, once they've gone through their process of internal audit, could they feed back to us, because we're obviously very interested in what the outcomes are. Well, I can't speak to that last bit, but Victoria in angioplasty has achieved 100% now by end of 2016 without mandating, and so that's one of our key strengths, is that we've been able to coax people along. So I guess in other areas it mightn't be quite as successful, but I mean there are people here from the health department. They might want to answer that question. I can't answer that.
I mean, one of the things that implies is that probably agreed to do it because they know it's actually not such a big problem. And when there are big problems, people understand it's a problem. That was the first issue. When it starts happening, I'll build this central management program. The second thing relates to you've got the STEMI country program going with a handful of hospitals. Clearly that needs to involve every hospital in Victoria. But STEMIs are about a third of the problem, two-thirds of the problem are non-STEMIs, and they really need to be involved. Because again, we know less than half the patients are sent home on adequate care.
Yeah.
The third thing, which relates to the follow-up, half the patients presented to hospital with acute coronary syndrome have known pre-existing coronary disease. The vast majority of those are not getting adequate secondary prevention treatment. To my knowledge, there's no ongoing registry of those cases. It seems to me the lowest hanging fruit, we really want to spend a few bucks to save the maximum number of lives, is to enrol all patients with known coronary disease into a registry, annual follow-up with a nurse-based rehab program, simply by phone call, making sure that they get managed properly. Anything on the pipeline along those lines?
Not that I've heard. We know that you mentioned this snapshot ACS study just then, and that is going to, there's another round of that. So that's not quite an ongoing registry, but does provide us with information, and as they go through time, we can compare progress over time. But you know, we've been together in different fora, and you've raised that point. You're a strong advocate for the idea of looking at ACS and post-ACS management, particularly around secondary prevention, and I agree with it. It's an important area.
Finally, just a comment on the abuse of registry data and the increasing number of reports. One that springs to mind is Derek Chu's Acacia study, where he looks at the association between outcomes with ACS and the instance of having coronary angiography. There's a clear association. So the implication in their article was that we therefore need more angiography units around the countryside, a network of them throughout Australia, so every patient can get an urgent angiogram. Whereas in fact the data in that registry showed patients in the country areas were not getting managed medicine properly. They weren't getting aspirin, statins, beta blockers, all the things that would work. So in the absence of good randomised trials showing the benefit from these interventions, we're seeing this complex black box statistical analysis suggesting that we need to be going along this direction, which I think is quite problematic and misleading.
I'll take that as a comment.
An example, sorry, is the recent articles in the medical journal about the new guidelines, is a registry analysis showing that patients more remote in northern New South Wales who didn't have access to urgent angiography, so who did get pre-hospital thrombolysis, had exactly the same outcome as the patients who were right next to the large hospital. The conclusion from that, to any rational person, was that maybe we don't need to have angiography units scattered throughout the countryside. It looks as if this might be just as good, but that's not the conclusion.
One last question, Leanne.
In
We agree those points are very valid and are challenging to be able to collect serial numbers and follow devices and patients going from one hospital to another are the inherent challenges within a registry. It's worth mentioning at this point that that same issue is being addressed at a federal level through ACOR, the Australian Cardiac Outcomes Registry, through a financial program that they've received from the federal government. And their brief is more in relation to what we'd call a contact or a device registry, following along which devices work, which ones don't, where the problems lie. Whereas our focus through VCOR has been a little bit slightly different. It's been more in terms of a clinical quality in relation to outcomes and appropriateness. So in some ways, you don't really need to know what the serial number of the device is in terms of whether the device was put in properly or whether there were an unexpected number of complications in relation to its insertion, that sort of thing. So they two go together, and they're not saying one is, but we as VCOR are focusing more on the quality side rather than on the device long-term follow-up side. So there are other people around who are also looking at that. In the end, of course, the companies also know who more or less who put their who is receiving their devices, and so there is some overlap there as well.
There'll be an opportunity to ask more questions towards the end of the afternoon. So thanks very much, Jeff. Our next speaker is Gil Shardey, and Gil's a cardiothoracic surgeon who's now retired and shares the commitment of all surgeons to ensure that the profession maintains high technical standards. Gil's been really instrumental in the development of the cardiac surgical registry. So, Gil, thanks very much.
So what do I do? Press a button somewhere? Okay, so it's always very difficult to follow Chris Reid and Jeff Lefkovits, because basically they say everything that needs to be said. So I thought I'd tell a joke, but in instance of time, I won't. Anyway, because we're already over. So we, as Chris has already alluded to, our registry started off because cardiac surgeons always had their own databases, and they were useless for comparison with anything. But this chap who's the first president of our society, Brian Buxton, it's not Terry Thomas, it's Brian Buxton, that photograph. He wanted to have a registry for a long time and wasn't too successful at it until this is the Bristol Royal Infirmary that Chris referred to previously, and they had some problems with paediatric surgery, and that came along, and that sort of frightened the horses, at least the cardiac surgical horses, a fair bit. So Brian sort of upped the ante and eventually got Peter Skillington to take over initiating the database. So Peter sort of deputised me, because I happened to be secretary of the society at the time, and we decided that we would try to establish this thing, and we couldn't get any money for it. So we approached the Kennett government at the time. This is not a political statement, it's a statement of fact and history. But they were too interested in selling the place rather than doing anything new. So we then waited until they were out of office, which didn't take too long, and then found these surfies down in Lorne. And they seemed quite likely people, you know, looked like they had some money. And it turned out that one of the surfies was the health minister, that's the guy on your right. I don't know who the other guy is, but he was quite influential as well. And we eventually got some money. The purpose of the program was, had all sorts of highfalutin intentions, but just for the purposes of today, we'll just talk about our sort of performance reviews and our quality assurance sort of program that we've established since about 2001 or thereabouts. So, as Chris has already said, the things that you have to have any sort of program at all is reliable data. Reliable data means two things. You have a data dictionary, which everybody has to follow slavishly, right or wrong. So if we decide to define the thing that arises, you know, in the east every morning as the moon, then it's the moon for everybody else until we change our minds. so that we know what to compare. We haven't, by the way, defined the sun as the moon, but it's just a concept. So it has to be, and also it must be as far as possible not gameable, because gaming is something that is a characteristic of, I think, particularly surgeons who are very sensitive to their results, about their results, because they fear this might come out in some future date, and indeed it will. So to do that, the CCRE has established a number of algorithms which internally checks the data that has been recorded by the various contributors to the database. The other thing is you need to have objective performance parameters, and this brings back to Professor McNeil, because fundamentally, if you can't measure it, if it's an opinion, then it's useless. So it has to be something that's measurable. Now, the ideal for this would be if we could take electronic data straight off whatever is recording it and incorporate that in the database, but we can't do that, so we have to have some sort of opinion situation occurring, and then we have to define the outliers, and our outliers have to be defined by a set of parameters that is relevant. The analysis had to be critical, and Chris has already alluded to that. We have to have a communication loop sequence. So we have to tell people what the problem is, they have to do something about it, we have to review the effects of whatever they've done, and then we have to remediate further if that's necessary. And that's a continuous process, which is the thing that we've actually developed. And finally, whatever we do, we have to have some sort of effective remedial procedure, which in the atmosphere of very tetchy cardiac surgeons, cardiac surgery units, is very difficult, as has been demonstrated just to me this afternoon, because one of the people one of the units who was going to be involved in our Vanguard study, or rather Chris's Vanguard study, ain't cooperating. And I'm always very suspicious of people who don't cooperate. So I've already said that the data should reflect the requirements, and Chris again has said this already. In other words, you have to gather data that is relevant to the information, to whatever you're trying to create. Our data was predominantly focused on performance rather than on process. So we were looking at the performance of units and cardiac surgeons. And finally, the data has to incorporate aspects which allow that data to be risk-stratified. We have to accumulate that data. We can't apply other people's risk stratification programs or algorithms to our data, because they are largely, as again the CCRE or the department has demonstrated, they are not relevant. So I just want to give you an example of what happens with our data to which people are meant to adhere. This histogram shows the 6 Victorian public hospital units. The green line is 2014, the blue is 2015, and it represents the number of procedures which the hospitals had reported as being urgent cases. Now, we tried to select urgent as a clinical parameter that gives us some idea about the risk of the procedure. And this has ramifications downstream into all sorts of statistical analyses, including the creation of the risk stratification algorithms that have also been created by Chris's people. So that's terribly important that this is reported accurately. Now, oops, said Daisy. What I wanted to bring your attention to is the triangles and the diamonds, which are a bit hard to see from the back of the room, but the triangles and diamonds represent the proportion of those patients that were reported as being urgent cases that actually were urgent cases on the basis of our definition. Right or wrong, our definition was that an urgent case is one that has to be done 72 hours after admission or after an angiogram, or after a non-elective admission or after an angiogram, okay? No arguments about that, ex cathedra, God has spoken. Well, as you can see, Unit A, which had a heck of a lot of urgent cases, okay? In 2015, well, here we go again, 10% of those urgent cases actually were urgent on our definition. Now, this is not saying they were really urgent or not urgent, but on our definition. So, therefore, this has ramifications on all sorts of things. There are ramifications on calculating their outcomes, because part of the risk stratification algorithm includes clinical urgency and also had ramifications overall in calculating that algorithm, at least as far as the coefficient for urgency, clinical urgency, applies. In other words, I'm so hot on this subject and I'm so distrustful and paranoid that I want to make this point again. And that is that no matter how powerful the animal, whether it's a lion or a cardiac surgeon, is, if they produce crap and they put it into a computer, okay, it's still crap. It might look better, might be shiny, but it's still not usable information. Okay, so in order to, this is a very serious topic. Actually, I'd love to find a line that could actually poo gold. Wouldn't that be fantastic? Okay, so now our intention, as I said, of our database was to identify outstanding performance, and fortunately, or unsurprisingly, VCOR, the physicians, have been able to find exactly such units that actually are much better than everybody else, or we couldn't. In the last 15 years, we haven't actually been able to identify anybody who's been any better, really any better than anybody else. We did find one group that didn't have too much deep sternal wound infection, but they used antibiotics which were incredibly powerful, like ticaplanin or something like that, which is much more harmful than the benefit that it provides, and I'll talk about that unit a bit later. So finally we decided, well, we will look mostly at substandard performance, and that's what basically risk sort of quality assurance is all about. And the principles of assessing these took us about 12 years to actually work out what the right thing to do is, and that is, every statistician knows that you need to have a decent denominator and numerator of the parameter. There's no point getting one or two cases, because that's what's reported in the Age or the Sun Herald anecdotes. So anything that isn't like that is an anecdote. And secondly, preferably it should be risk adjustable or risk adjustable. So therefore, we analyse, of all the things we do, coronary artery bypass grafts and aortic valve replacement, because that's the commonest thing that we do. And we only do about 4 operations, you know, sort of. So we don't do pretty sort of one-trick monkey type of people, but nonetheless, they're the two that seem to do more of. And of course, aortic valve replacement will disappear in the near future, because these other guys have worked out some ways of shoving something up your groin and Bob's your uncle. Anyway, we have a module, by the way, that actually records TAVI data as well. So we've just introduced that. And the other important thing, the critical thing that's happened is that we analyse the data that we do analyse over not just 3-month periods, but a rolling 36-month period. And that has enabled us to identify factors or problems that were not apparent before, much to our, I guess, embarrassment. So the relevant performance parameters, I won't sort of dwell on these. They basically the things on the left. The ones on the right are some possibles that we might look at the future. The thing is that our most recent contract with the Department of Health seems to imply that we, the cardiac surgical group, will be expected to much more rigorously police outcomes than we have hitherto, because the department really does not want to have another Bacchus-Marsh type situation happen, which it won't in cardiac surgery, because in experience for the last 15 years we've been pretty good, but not hitherto anyway. That's one of the problems that we sort of have is do things very thoroughly. Now, Chris already alluded to control charts. This is a control chart, and you can see that one unit is getting a bit close to the upper limit, but statistically that doesn't make any difference. So whether you're sort of here or there, statistically you're the same on a control chart. I have a sneaking suspicion that you're not really the same, but statistically you're the same. Okay, clinically I would be worried about that unit that was sort of up there. Anyway, if you risk adjust that, what you finish up with is that unit comes down a little bit, but another unit that looked over before is outside that. Now that means one of two things, or it's possibly that the risk adjustment algorithm is not very good, or it's a real finding. Now if that's a real finding, we look at it that's the reason we look at things in several different ways. And Chris again has stolen my thunder, bugger always does. We look at it obviously on a control, and we look at it with Q-sum curves. And this left side curve is an ideal curve. This is a unit which has had no mortality for the period under question, and therefore the curve falls in an even way from beginning to end. We look at unit 22, okay, and this is a very unpleasant curve. So this supports the concept that really there is something wrong with unit 22, because each upward step represents a mortality, and as you all know, the height of that step represents, or inversely represents, the difficulty of the case that was performed. So it's pretty important to be pretty thorough statistically, because that's our initial identifier. As I've said, we do these quarterly reviews where the CCR prepares an analysis of the current and previous quarter's data. And 3-year rolling data. There's a steering committee that actually looks at that, and then there's a report that goes out to the contributing units, to the heads of units, and more recently to the medical directors of the hospitals concerned. The reason for that is that we've found that the heads of units sometimes keep this stuff quiet. They don't tell anybody. And they're supposed to at least tell their surgeons. They don't. Because I asked a lot of surgeons at one of our annual general meetings and said, do you get these reports? And they said, huh? So we are now going to sort of, we have to make sure that the right people get that information, because if they don't, we're nowhere. We can't do anything. And then there's an initiative called Vanguard, which I think is probably, well, the report of which will come out soon, or else will be the initial analysis will come out soon, and Chris will tell us what all that says. So we have this concept of escalating interaction, and that is if we find a negative outlier, two things happen. The CCRE interrogates its own data set, and I'll just go into that in a little while, and the unit is asked to review some factors which may affect whatever parameter they've been out of kilter on. All these things are then combined, and the unit tries to rectify the factors that have been found that would perhaps affect or influence the outcome in which they are deficient. And then the data is reviewed, and if everything's fine, we just keep observing. If it's not fine, then we have to remediate, and that brings in a thing called a Peer Review and Quality Assurance Committee, which is a high-level committee of our society and also obviously the state departments of health. The sort of thing I mean about how we try to help units to identify what the problem is illustrated by this new renal impairment sort of concept, where on the left you see that when we had a couple of units that had a problem with high levels of new renal impairment after surgery, and we wrote to them and said, okay, so the first thing that we did was we looked at all this sort of information, age, procedure type and so forth, that we thought might affect that outcome that we accumulate in the database. And we identified those ones where that unit was different to other units. Did they have older patients? Did they have more cardiogenic shock? Did they have lower left ventricular ejection fractions and so forth than any other unit? Because we don't have any way of risk stratifying new renal impairment. Okay, we just don't have that algorithm. And then there are other things which we don't collect in the database, but the unit may look at its own processes, such as what is their precise vasoconstrictor use. We don't collect, we say yes or no, but not how much, how long, what for. What sort of antibiotics do they use? What sort of fluid management do they have? And that's just a guide for those units to look at their own data and then define where the problem may lie. And then the whole thing is sort of reviewed. So our outlier experience has been essentially confined to coronary surgeries, I've said, where, as I've also said, there are no definitive instances of outstanding performance. We've had several instances of individual surgeons apparently providing substandard performance on annual reviews, but they haven't persisted into the next year, so we're not worried about that. But we have had 3 instances now of unit substandard performance, and these have been revealed on this 36-month analysis. So Unit 1 had a high level of renal impairment on 36-month rolling analysis of data, but not on the quarterly data. So we missed it for a couple of years until we introduced this 36-month rolling sort of technique. And then we advised them, they reviewed their process, they've remediated whatever they had to do, and so currently they are within limits. And we helped them remediate that by giving them that list of saying, look at this stuff, because this might be something that might help. And they looked at a whole lot of other stuff as well. So it was a sort of cooperative effort. And the other unit we've had with this problem is similar thing happened, but they'd already got onto it themselves and they sort of fixed it really before we had too much to sort of do with it. And right now we're involved with another unit that has deep sternal wound infection problem. It seems to be more frequent than other units. This unit is well known to sort of the authorities, and currently we looked at our database, we are trying to help them get through the problem. They're looking at their own processes, and this will take some time to rectify because they had some significant sort of structural problems with that. So this is this thing that Chris was referring to, the Boston group did this study, and what you should see there is a nice symmetrical pentagon. Our pentagon with the red arrows, a bit like after 9/11, you know, when the plane crashed into the one side of the pentagon and sort of flattened it. So we've got this flat bit, and that's the bit that says, have we driven change? In fact, we haven't, except since then we've had these 3 cases, because since then we sort of G'd up our statistical processes and we actually found problems which we didn't know existed before. Thanks very much.
Thanks, Gil. Any burning question? Leanne?
Thanks very much for the study survey done by Prof Danny Liew in this field. Do you have any plans to incorporate compliance hospitals into the inspection in the future?
Oh yeah. So we have eight of them, and we are hoping to get another 7, provided, you know, we're negotiating with another 7. The problem is that they don't want to spend the money, by and large, and so I think they have to be coerced in some way, which has to be mandated. That if you've got a unit that does cardiac surgery, you have to be part of the database, and that can only be mandated by people like the Australian Commission for Safety and Quality in Healthcare, or I don't know, by the private funds or something. But we're working on it. John.
Gil, for a particular cardiac surgeon who might work at a private hospital and 2 different public hospitals, any way that you have to amalgamate the data?
Yeah. Each surgeon has a distinctive code, so we can look at the data of any surgeon who works in participating hospitals. So we can look at them, what they do at this hospital and that hospital, or the whole lot together. I must say, I don't think this particular form of database is terribly good at evaluating individual surgeon performance. It's not really focused on that, but we can do it, and we have done it. We've been asked to do it. We've done it in a number of requests from hospitals and from a surgeon who APRA wanted to have some information on, that we cooperated with. The surgeon up and died before we got anywhere, so that was unfortunate.
Thanks, Gil. Our next speaker is Karen Smith. Karen is leading the research and evaluation component of Ambulance Victoria and has been instrumental in the VACAR registry, and Karen's going to tell us all about it. So thanks, Karen.
Thanks very much for the opportunity to talk about the Victorian Ambulance Cardiac Arrest Registry today. So just a bit of an overview of Ambulance Victoria to set some context. So we provide the pre-hospital emergency care for the entire state and operate a 2-tiered emergency medical response with MICA paramedics and advanced life support paramedics. And we also if identified at the point of call, we respond. Community emergency response teams and firefighter first responders to cardiac arrests in select areas of Melbourne and also in rural areas of the state, but not completely across Victoria. And our protocols follow the ARC. So we've been lucky enough to have electronic patient care records introduced in Ambulance Victoria since 2007. So that has significantly facilitated the cardiac arrest registry in terms of moving away from a very manual process through to an electronic case ascertainment and plus filtering of data into a holding section of the registry that's then quality controlled by data processors before moving fully into the registry. Just a little bit of information that I'm sure I'm speaking to an audience that knows all about it, but sudden cardiac arrest is obviously a significant public health problem, and the prognosis is very much determined when it occurs out of hospital by the quality and timeliness of ambulance paramedic interventions. And it's really recommended, it's really seen as a sentinel measure of the quality of ambulance care. So if we have good cardiac arrest survival, the premise is that we're doing well with other complex patients. So it's seen as a key indicator to benchmark ambulances internationally. This is just an old slide from Graham Nicol, who's done a lot of work in cardiac arrest outcomes in the States, just highlighting the disparity in outcomes across different areas in the US. And if you can see down the bottom with ventricular fibrillation, so shockable rhythms, we have survival to discharge sort of ranging from, almost 8% in Alabama to 40% in Seattle, which are seen as the gold standard in cardiac arrest survival outcomes worldwide, although there's quite a bit of debate about how they define who they include in their reporting outcomes. So in Australia, we report our outcomes to the Report on Government Services, which is a publicly available document. So that's annually collected, but not all of the states are able to collect hospital discharge data, so it's only reported for survival to hospital. And also the footnotes with the reporting is often bigger than the reporting in terms of data quality and definitions, so we've got a long way to go in terms of standardisation and allowing proper comparisons, and there's some of the smaller data collection areas in particular, the quality of the data is questionable. So obviously preaching to the converted, but the first step to improving survival rates is to begin collecting the data and to better understand performance. So again, just sort of reiterating the value of a cardiac arrest registry, it's really seen as a sentinel data collection for ambulance services worldwide. And it's even been suggested by the American Heart Association that cardiac arrest should be designated as a reportable event to facilitate monitoring and improvement in care. So we're lucky enough to have the Victorian Ambulance Cardiac Arrest Registry at Ambulance Victoria. It was initially able to be established by funding through the Department of Health. We had for a long time a separate funding stream funding the registry. It now sort of forms part of the bottom line of the grant we get, annual grant we get from Department of Health. It's classified as quality assurance with ethics approval from Department of Health Ethics Committee, overseen by a multidisciplinary steering committee, and we aim to collect data on all cardiac arrests attended by ambulance across Victoria. And the data actually dates back to late 1999. We have over 80,000 patient event records in the registry at the moment, and we report broadly to a steering committee, to the health department, to the executive, to our board, to the Convention of Ambulance Authorities, and then to the Report on Government Services. Cases are identified generally by an electronic filter on it, using our electronic patient care records, but we also have a manual sort for the few paper PCRs that we have, and also team managers send in their ECGs after they've audited cardiac arrest cases. It's based on international criteria, the Unstein definition, and it's supplemented with hospital discharge data from over 100 participating hospitals that we manually collect outcome data from every month, and we have to do ethics updates on an annual basis to over 100 hospitals, so it's a very onerous process, but worth it in terms of being able to report on discharge data. We also have some coroner's data, and we're lucky enough to be one of the few registries that collects quality of life data at 12 months for adult patients who survived a hospital discharge. We use the SF12, the EQ5D and the GOS. We outsource that function to Monash University, who do a very good job. We have a lot of quality control, the usual registry with mandatory fields and significant validation ranges and retrospective audit of 10%, plus we have a lot of targeted reviews, and the data is used extensively for research, which is also a great way to quality control it, because you always find something when you're doing research on the data. This is just some information on the incidence that we see. So we see a higher incidence per 100,000 population in rural areas compared to metropolitan, with about generally over 5,000 cases per annum attended by Ambulance Victoria across the state. Demographics sort of typical of cardiac arrest patients, so predominantly male, half of them bystander witness. We have a very good bystander CPR rate in Victoria, 71 to 74%. In patients where resuscitation is commenced by the EMS, and that's been significantly increasing over the decade, which is great to see. About a third of them present in a shockable rhythm, and just almost a third in rural regions. Survival has been increasing over the decade. To hospital you can see the increase, but it has been sort of slowly declining. Not reflected in our discharge data, but that gap is narrowing, so we need to have a good look at sort of what's driving that. I think probably more asystolic patients getting to hospital but not surviving to hospital discharge. You can see most of our survival gain comes in our VFVT patients. So at the moment we're sitting on around 53% to hospital and 34% surviving to hospital discharge. This is just showing it from our annual report, which is available on our website. So if we risk adjust for predictors of survival such as bystander CPR, arresting in a public location, shockable rhythm, we've seen about a threefold increase in survival to hospital discharge over the period that we've been collecting data through the registry, which is very promising. And that's despite increasing response times with increasing demand on ambulance services. This is just a slide to show that if patients do survive to hospital discharge, adult patients, we haven't got quality of life in children, but generally show very strong quality of life outcomes comparable to their age and gender peers in the population. And this is just EQ5D data, and the vast majority of patients on the EQ5D actually report no problems in all of the domains. Although Emily Andrew, who works for AB, has done a bit of work in the quality of life space for cardiac arrest patients, and EQ5D is probably not the best tool to measure them with. It's got quite high ceiling effects, and we probably need to look to move to exploring some different quality of life measures there. This is just a slide showing, it's probably a little bit hard to see, but a paper published by Ziad Neme, who is also does a lot of work on the registry, just showing the improvements in outcomes over time with some of the various initiatives that have been implemented by Ambulance Victoria, things like introduction of first responders, significant investment in a CPR awareness program, simplification of the CPR dispatcher instructions over the phone when people call 000, and things like that. That's published in available to read. So in terms of using the registry to drive clinical quality improvement, which is the main purpose of the registry, we have significant challenges because we have a very disparate workforce. Our paramedics work in teams. We have over 500 teams across the state, so in a way we have 500 sites. So using the sort of standard methodology to identify outliers by site is extremely challenging, and in fact some research done by one of our paramedics who's doing a PhD at Monash University looking at exposure to cardiac arrest and outcomes, where she linked VACAR data with AV human resources data. She showed that on paramedics are exposed to a median of 2 cardiac arrests per annum across the state. 11% had no exposure in the period that she looked at, and she actually managed to demonstrate a improve survival outcome with increased exposure to cardiac arrests. So sort of highlights the challenges that we have when we're sort of trying to look at practitioners, given the level of exposure that they have. Obviously our metro MICA paramedics have higher exposure. But some of the things that we do with the data to improve or feed back into the clinical quality improvement process is we have key limited occurrence screening categories where we review all the cases. So we review all patients who have a pulse on ambulance arrival but subsequently die in ambulance care. We review all patients who are defibrillated. We look at all patients who have rapid sequence intubation, so many cardiac arrest patients who achieve a return of spontaneous circulation have RSI performed by paramedics, so those cases are reviewed in detail. We also look at, in particular, metropolitan patients who are transported to hospitals without PCI-capable facilities. It's only around 5% of metro patients, but we review why they didn't get taken to PCI. The review happens with initially it's reviewed by one of our senior paramedics, a clinical support officer. If they think that there's significant variation to clinical practice guidelines or there's an issue that warrants formal review, it's then lodged into our formal clinical review process, the outcome of which can range from a level 1 variation, which is considered a severe variation where the care or lack thereof has contributed to a significant adverse event, through to no variation found. And those, obviously the results of those reviews are fed back to the paramedics and the teams, and various plans are put in place to deal with whatever the outcomes were. We also report on a quarterly basis to the regional managers how their regions are going. So that's done on a 12-month rolling basis, given smaller sample sizes in rural areas, to give them some context around how their region is performing in terms of commencing resuscitation and also survival outcomes. And we show them some risk-adjusted outcomes. So this is survival to hospital discharge for the last 12-month rolling period, and then also the odds, risk-adjusted odds of paramedics actually commencing resuscitation in their area. So paramedics can withhold resuscitation if there's been a prolonged response time, if the patient's in asystole, if there's no signs compatible with life. So they can follow our clinical practice guidelines and make the call not to actually commence resuscitation. But it's interesting when you look, even when you adjust for things like response time and rhythm and bystander CPR, there's varied rates of whether paramedics actually commence resuscitation across the regions. This is just an example of how the registry has been used to drive a system change based on outcomes. We're not sure in hindsight whether it was a good system change, but using the registry data, it was identified that there were a significant amount of patients where there were delays to defibrillation. So from arriving at the patient and ascertaining the patient was in a shockable rhythm, that was often taking over 3 minutes to perform the first defibrillation. So there was a decision made by a different division who were in charge of the clinical practice guidelines to mandate that the initial rhythm should be monitored in automatic mode, not manual mode, for the first defibrillation. That was introduced in 2012, and we've now got sufficient data in the registry to go back and look to see whether that change has led to improvements. But in fact, on a preliminary review, which we're still processing the data, it actually looks like, in fact, maybe that was not the right decision. Looks like we're missing fine VFVT, and the proportion of patients in VFVT has declined, and it's potentially actually driven a decrease in survival. So we'll go back and review whether that was the right decision. But it just shows the power of the registry in driving change and then looking to see whether that change, in fact, was the correct thing to do. Just to summarise, so we also provide data on key performance indicators in the statement of priorities that Ambulance Victoria signs with the Health Minister. It also fosters a very large research program and is used to facilitate clinical trials and make clinical trials more economical in the terms that we provide a lot of outcome data for trials on cardiac arrest patients. It's used to monitor the fire first responders, inform where public access to fibrillation would be most efficient, and looks at areas of high exposure and low bystander CPR participation to see where we can target our CPR awareness programs. And we also contribute to the AUSROC Epistry, which is a Centre for Research Excellence funded by the NHMRC, which AV is one of the participants. And the aim of that is to actually try and establish a national registry. It's actually now got all of New Zealand data in it as well. So that's going to be very interesting, and the first time that we'll be able to do on a national level, probably properly benchmark and do risk-adjusted outcomes and look to see where systems actually make differences to outcomes, although we're currently having significant debate on defining the inclusion-exclusion criteria of how we're measuring outcome and how we're actually doing case ascertainment for that registry. So that's very interesting when you start asking other states what they drop off from their resuscitation category in terms of if resuscitation is ceased after 10 minutes, they don't necessarily report on outcomes and things like that. So that's been a fascinating experience. We also produce an annual report which is publicly available on our website. And just some future work where I think we could really look to do some improvements in terms of driving clinical quality improvement is we're looking to establish a case review group, which is a bit like the State Trauma Committee case review group, where we'll look at the care from the initial call and whether it was coded by ESTA as a cardiac arrest, did they get dispatcher CPR instructions, right through to taking the patient to the appropriate hospital. The challenge we have at the moment is that we have electronic patient care records that are retrospectively entered by paramedics once they've finished treating a patient, a lot of writing on gloves and trying to remember what time and what dose and everything like that. And then we have obviously the ECGs. But we have moved to Zoll monitors, which we have got some CPR pads or defibrillation pads which actually capture the depth, rate, fraction and things like that of CPR. So we'll actually be able to trial some objective peer sort of feedback on how well paramedics are doing with resuscitation. And we're also looking to try to get funding to actually trial what a resuscitation improvement bundle might look like. And just some of the other things we're doing to sort of try and drive improvement is we're currently looking at traumatic cardiac arrest that don't survive to hospital and linking with NCIS data to see whether there's preventable deaths there that could have been better managed by paramedics. And this is just an example of Scottish Ambulance Service who have the defib pads that actually objectively collect the data, and they provide a really neat summary back to paramedics on how well they did in terms of rate, depth, their hands-off time, their no-flow time, you know, how long their hands were off the chest when they were intubating and things like that. And I think it's really powerful, and I think in terms of Ambulance Victoria driving improvement, we'll get much more improvement from being able to do something like this than some new drug, and really hope that we can start to move down that path. So in conclusion, we're one of the largest single-service cardiac arrest registries in the world. We're a single state, so reduces heterogeneity, and we've seen improvements in survival over the decade despite increasing response times, and we use it extensively to benchmark and monitor our quality of care, but we also host a significant body of research from the registry. We have a great team of people who I'd like to acknowledge, data processors and data managers, and Mariana, the research fellow who oversees it as well. So thanks very much.
Thanks very much, Karen. Any questions? The 100 ethics committees must be a full-time job for somebody. What's the future there? Are we seeing any streamlining opportunities?
No, to be honest, not in the near future. In fact, yeah, some of them where we've had like ethics approval for years, they're just starting to come back and, you know, revisit and question. We have to sort of dig up all the original applications, and so yeah, It's most of them accept a standardised annual report, so that's okay. Yeah, but it's it's an onerous process.
Challenging one.
But worth it.
John.
Karen, how many years till you think we can benchmark between states?
Look, I think we'll have the first sort of paper out on that with a year's worth of data next year. Yeah, which will be great. Yeah.
Yes, Brett.
Oh no.
Just following what you were saying before, one of the ways you could use the registry is to look at the average time it takes to get the case. I noticed Gippsland was a bit of an outlier, pretty hopeless case on arrival, but then you've got such a huge expense. And since the pre-hospital common licence program appears to be so successful, there needs to be a very strong case. Look, we don't have enough evidence to the registry to do it time. We're the main provider of licence treatment. That's where the resources should be directed rather than
Yeah, I know. Yeah, Gippsland certainly is on our sort of top 20 in terms of if we got extra money from the government, we'd put some extra resources out there. And but when we do show the regions their outcomes, we adjust for response time.
yeah, but what you need to show the politicians that there is response time is long in other places than the whole history.
Yeah, well, we have to publicly report our response time performance on our website every quarter, and so by LGA, so you can go in there and see how poor some of the LGAs are. Yeah.
Terrific.
Thanks.
Thanks very much. Well, we've had three registries really talking about driving change, and that's a theme I think consistent across the board. The value of these registries is really it is looking at ways of improving. Please use the next 20 minutes to have a cup of tea or a cup of coffee, a little bit of an afternoon tea and a networking session, and we'll reconvene at 4 o'clock, about 20 minutes from now, talking about the Fontan registry. So thanks very much to all the speakers. All right, welcome back everybody for the second session for this afternoon. Our first speaker is Yves who's been responsible and looking after the Australia and New Zealand Fontan registry, and Yves is going to give us an overview of their activities. Thanks very much.
Thank you very much. So I have some disclosure, but the main one is that I'm a pediatric heart surgeon, and that come inevitably with some biases. You have to be honest, we've talked about mainly old people up to now, so let's talk about some young people. So like Victoria, she was one of my medical students. She's probably like some of your kids. She's brilliant, she's beautiful, but she's got some peculiarity. She was born with half a heart. So you know that most of us were born with two ventricles, a left ventricle that pumps the blood into the body and a right ventricle that pumps the blood in the lungs. So there's a few kids around who were born with only a single pumping chamber, and thanks to a series of operations, the last one being the Fontan procedure, this patient can be kept alive, but there have been great doubts about the long-term survival. It was believed they would all die in early adulthood, and that's why Victoria, Cam, Megan, every day of their life in their early 20s, at an age where I thought that I was indestructible, every day of their life they're afraid of death. And so we wanted to a little bit elucidate that. I will explain you a little bit what is a Fontan and then the outcomes, and I will insist on the benefits so far of the registry. So the Fontan, I call it a little bit the trash bin of pediatric cardiac surgery. Whenever you cannot repair the heart with two pumping heart chambers, you direct them to the Fontan. And so you do it for a vast variety of lesions, and you have to keep in mind that you have to have a series of operations, and that's come with a cost of about 15% if you're born with a single left ventricle, and that's interesting. And about 25% if you're born with a single right ventricle. And the results I'm going to give you start after that, after the Fontan. Over the years, there have been different techniques. The first one on the left, and the most recent one that has been adopted all around in Australia and New Zealand quite early compared to the rest of the world, the extracardiac conduit. The principle of the Fontan is that the ventricular chamber ejects, it's very painful, but eject the blood through the microcirculation, and that's enough to generate still higher pressure in the vein than normally, about 5-6 times the pressure in the veins that you and I have. And that's the driving force for pushing the blood through the lungs. What is the outcome of this extraordinary circulation? Well, there was doubt about the outcomes, and that's why we've built up the Fontan Registry, which collects the health data of all patients who had the operation in the region, in Australia and New Zealand. And we have 20 patients who refused to participate, but all the other ones are in the registry, which means that it's the only population-based registry of the kind. And even though we have small countries, it's the largest one in the world. We built it up to redefine real expectations. We change practice, but we want to monitor as we change practice what we do, to build up politically valid information, to do what we need to do for this population at risk, and to have enough patients to build up the research, because they're a very heterogeneous group of patients, so we need a lot of them to do the research. And I'll try to demonstrate to you that, again, this registry improves the quality of care. We included all patients. We have an opt-out consent. We have a possibility of getting phone consent for all our studies as well. And we have a waiver of consent for patients who are dead or not traceable. We can keep the data that are in the hospital databases. We have a steering committee with all centers taking care of these patients, representative, and some parents and patients representative. And we have a complete collection of a very limited data set, and then we have more in-depth research with retrospective work being done individually and some cross-sectional study that are ongoing. We started in 2008, and we had our major seminal paper in circulation in 2014. We have 1,375 patients alive in the registry today in Australia and New Zealand. That's the seminal paper from circulation, and that shows that actually the survival is much better than expected. So even for the worst case Fontan, it's 75% at 30 years, and that's the first time we have 30 years perspective, way better than anybody could have expected. And even for this worst case Fontan, 2/3 of them are working at the end of the follow-up. 2/3 of them are good citizens paying taxes. And we can see that because they're not dying as much as we thought, the population is increasing, so the number will double within 15 to 20 years. So today it is estimated there's 50 to 70,000 of people living with Fontan circulation throughout the world. We expect that to double. So you all have heard about cystic fibrosis. We're going to have as many patients as cystic fibrosis within 15 years in Australia. Yes, the survival is better, but still 40% would suffer a major adverse event before reaching adulthood. And that may be a stroke, a pacemaker, a major bleed, a fast heart rate, something, a reoperation, something that requires hospital stay. And they're not debilitated, even though they have half a heart. These are normal people. You look at them, you wouldn't know they had any operation. And yes, some of them had stroke, some of them have impaired, but the majority are well-functioning individuals that work and study. What can we do for them? Well, they have progressively failure, and we know the clear outcomes, death and transplantation. But there is a slow slope that is, for the time being, poorly defined. There's some complications that we have defined, but we don't know exactly why they're failing. The people have said, well, their heart is failing. It doesn't seem to be the case. It seems to be pumping, but maybe it's not filled enough, so maybe it doesn't relax enough. Maybe lungs decrease with time. We actually don't have an idea. So I've tried myself to look at the original data. I know that we have a large number of files. We're trying to find why they're failing. And I'll give you some example. With this type of circulation with high venous pressure, it puts a lot of strain into the organs, because there is a high pressure at the back of the liver and at the back of the kidney. So we did a cross-sectional study, which is the largest one done so far in the world. We just had the analysis, the first analysis of these patients. We looked at the content of fibrosis in these patients. Well, 15 years after Fontan, 70% have abnormal content of fibrosis. So some of them, not a lot of them, but some of them will evolve clearly to cirrhosis. 80% have an abnormal fibro test, which is an amalgamated test of different blood results concerning the liver. And not all of them have severe abnormality, but the majority have them some abnormality. If you look at the kidney function, well, 35 of these patients have impaired renal function. Mildly impaired only at this stage, but we know that that's something that is pending. They're going to come to a more severe degree of liver and renal failure, and that's one of the things that will contribute to their failure. But we can do things about it. Renal failure, that is something that you may or may not know, but there's current medication, captopril, enalapril, the ACE inhibitor, are the standard treatment for renal failure of all causes. And so it may or may not work in Fontan population, but that's something that we can do. So we're going to start, now that we've seen these results, we're going to launch a prospective randomized study to see if the glomerular filtration decrease more slowly if you treat these patients in the Fontan population. Other solution for this patient is probably, trying to sort out the mess about medications. There are warfarin or aspirin, ACE inhibitor, while people say that it has absolutely no interest, and we don't know how to treat these patients, and that's why we're trying to sort out with the registry. The heart transplantation was quoted as a final solution for every one of this family at the beginning of their journey, and only on the 1,300 patients, only 34 heart transplantations have done so far in Australia. It is more complex, they're more at risk, but the real issue is this one. We have per heart, we've had in Australia and New Zealand 80 hearts available for transplantation every year, and not a single increase in the last 7 years. And we're doing 60 Fontan per year. There is no way we're going to have enough hearts for all of these patients. So we have to look at somewhere else. And my personal belief, and that's why I'm, as a surgeon, interested in these patients, is we're going to put artificial hearts in this patient. And some of my colleagues in Indianapolis is actually the furthest one, and he's got a machine that is specifically designed for this population. We have survived so far mainly because of research funding, and we're applying in the future for another large grant, and we have a partnership grant that has helped us a lot to survive. But we have a budget, a running budget of about $200,000 per year, and we had some private donation as well, but it dwindles out year per year, 50, 30, 20,000 this year, which means that we have a shortfall of close to $90,000 this year. What are the benefits to such a registry? Well, first of all, it has made the reputation of Australia and New Zealand. There's not a single talk on the topic anywhere in the world where our results are not quoted as the gold standard. And that has an effect when we're going everywhere. It has an effect on the national collaboration. Everybody, for once, adult, pediatric specialists, are sitting on the same table, and that brings a dynamism and the feeling that we can achieve something. And then from this, we're trying to build up larger projects in congenital heart disease. We have the leverage, because of this reputation, to build up international collaboration. So I have organized in Bordeaux, because the first Fontan was done in Bordeaux, and it's a nice city, a meeting in June with 18 of the most world experts and the people who had the biggest access to database, mainly Europeans and North Americans, to sit down and say, okay, what are we going to do with this population? And one of the things that we need to do is we're going to do merging the databases and try to identify scoring for these patients' population to see, identify better on where in the slope of failure they're sitting. We are currently improving care of these patients. The first factor is that we follow them better. I don't know if you know, but when you have a chronic pediatric conditions, you go to adult care, normally in the best institutions, like in Toronto, where they just have to cross the road, you lose 50% of the patients. When we looked at the beginning of the registry, only 30% of the young adults were still followed. Since the registry, 80% of those who were regularly followed, who were regularly in contact with the registry, have a follow-up care, while only 20% of those who are not in regular contact with the registry. We've looked at the difference between aspirin and warfarin, hey, not exactly the same kind of drugs, and we found in a propensity score matching analysis no difference between the two. And warfarin is much more heavier and much more costly as well, and I'll talk about that. We looked at the AC inhibitor. A third of the patients are on AC inhibitor, and only a third of this third have really a reason for it. So we're pouring medication on top of their head with likely not much rationality. Heart transplantation. And I said, I've quoted you a relatively small number of patients who have heart transplantations. Well, it had bad reputation for a while because of a large multicentric analysis of the results after Fontan. And we've demonstrated in the red line here that in Australia and New Zealand, we have the same survival in these patients than matched patients for age with dilated cardiomyopathy, so a general heart failure that has normally much better results. But more importantly, what we show is that the line in red is in the states where actually heart transplantation was done, and there was only 2 regions in the whole area where we were offering heart transplantation for the Fontan population. We've checked, they have the same rate of failure, but if the patients are in the area in red, they have access to heart transplantation. If they're in the area of blue, up to now, they have no access to heart transplantation. That had made a lot of noise within our community. But actually, the people in the area in blue are not changing their mind, and they will give better access to heart transplantations once they've seen the results. So it is changing practice. We are working closely with health economists, and I have to say I didn't know exactly what we would expect from that, but I'll give you an example of how it can impact care. Well, I thought, first of all, that I was the expensive bit of the lot as a surgeon, but actually I found I'm cheap. The cost of hospital care in pediatric hospital for congenital for these patients is about $490,000 up to the age of 18. Only half is up to the stage of the Fontan because of the operation. The other half is afterwards. So they cost more than $10,000 per year, far more than the normal child. And when we look at the cost, well, the biggest cost was cardiac surgery, and then the second biggest cost is operations that are not cardiac related, and we're investigating that because I have no idea what this operation would be. But when you look at the costs that are not related to surgery, it was ENT, and it was ENT because of dental care. And I thought, oh, that's surprising. That's the biggest lot beside operations. And then I go back to the head of dentistry in the hospital. I said, oh, yeah, we know that. Oh, your patients, they're terrible. They have horrible teeth. And so we're trying to think, but why would that be? Maybe they're a bit slack with these sick kids and they give them sugar. Or they may have a different oral flora. And actually, in this panel in Bordeaux, when we discuss, these patients live with increased pressure in the veins, and the lymphatics, the little channel that drains the lymph of these patients, are also under tension. So they lose protein, and they lose white cells, and so they're all lymphopenic. So actually, yes, they do have a different oral flora. And the beauty of it is that the guy from the dentistry department said to me, it's easily preventable. Send us your patient at 2 years of age, and they're not going to have this problem. So we can affect, on smaller aspects, the care and the cost of this patient. Another point is that there's some drugs come in on the line, and I cannot say which drugs, but it's not very difficult to find out. There will be a randomized trial on the most promising drug at the present time. The Australians will be the first one to get access to the drugs 2 years before North America and Europe, because we organized as a registry. Then we're improving the model of care. I've told you about the transition to adult care. Well, because of the money we got from the HMRC in a partnership grant to improve the transition from child care to adult care, we have a model of transition nurse and youth mentor, and we're transposing this model. Right now, we have already, we're paying for nursing staff in New Zealand, New South Wales, and South Australia. But obviously, when we do that for the Fontan population, it has a spread-out effect on the whole patients with congenital heart disease. Another way where we're improving the model of care, we've done a cross-sectional study of the quality of life. What came surprising from that is that 27% had markers of anxiety that require clinical care. And so we are now building up access to psychological care for these families and children. We have in our cross-sectional study put a proposal to study them with cardiac exercise MRI. That is the first time that in the regions we're going to do cardiac exercise MRI in this population. And because of that project, I'm not sure we're going to find great science behind it, but because of that project, we have the first clinical applications, and we first now start to investigate the other patients. We've shown that actually the best thing we can do for them is to train them. Resistance exercise training, body building of lower limb muscles, and we've demonstrated that in a recent publication and in a work where we train them at home. And that's the proposals that we have for the NHMRC. I hope that some of you were sitting on that panel, and we'll give the $1.5 million to have a national program for exercise training. And finally, also what has been very important is we build up a community. So we have Education Day, we have a Facebook page, we have a registry website, and you look at these, nice stories of the kids winning these surfing championship with a Fontan, and it decreases costs. And the example is, for example, aspirin, warfarin. There will be a trend of changing from warfarin to aspirin. $850 per patient per year who are on warfarin. Some of the costs from their own pocket. That if the majority of them, or 2/3 of them, switch from warfarin to aspirin, that's $400,000 less per year per healthcare. Plus also the fact that we've shown that if you're on warfarin at that age, they're osteopenic. They break their bone, they have more care for a fracture. I've talked to you about psychologists. ACE inhibitor, that's not very costly, but still, it will be nice to be without that drug. By having better follow-up care, by following them better, it has been demonstrated, when you get them before the complication develops, you get a cheaper care. I've told to you about preventing complication, like the dental care and early detection. Better care is cheaper care. And I'd just like to finish by quoting one of my mentors, Tyrone David on the left. He used to tell me that if you have two patients who arrive with a valve infected, if you have 85 years old, renal failure, terrible status, well, if the guy comes with his own valve that gets infected, you can say, all right, leave him alone, we're not going to operate. But if the patient that comes to you has infected a bioprosthetic valve that you put in his body, it's your responsibility. You should operate the guy who had the infection of the bioprosthetic valve you put in more than the other guy, because you have a duty of care to these patients. The majority of our kids never ask to be there. We put them there. So what we have to do is we have to find the optimal treatment to give them the longest possible life. Thank you very much.
Any burning questions? Great example of actually some of the research you're doing really driving some change in terms of how these patients are managed. So thanks very much for that. Our final speaker this afternoon is Danny Liew. Danny's the chair of clinical outcomes research, and with a specific focus on health services and health economics. And Danny's going to look into the crystal ball for us and hopefully give us some idea about future developments.
Thanks very much, Chris. Thanks, everyone. I'm conscious that it's late in the day. I've got about 10 slides, so I'll go for 10 minutes or so. I'll bore myself, let alone you people, if I go any longer than that. I'm going to talk about what I perceive to be future developments for the registry space. It's very exciting. This is a rather aspirational list, but I don't think we should apologise for that. I mean, who knew we would be where we are now, 10 or even 12 years ago. So these are the sort of key things that I've identified, I think, would be things that we should aspire to. Some of them are already at hand. So in terms of performance dashboards, this is a project that we've actually just started. We're scoping out And we're starting with VCOR that Jeff is aware of, and it's providing performance dashboards for the clinical sites. It's giving these clinicians and the units information as real time as possible about their performance. So this is an example of a tool that we used while I was at the Royal Melbourne last year, and Jeff and Leanne might be familiar with it. It's using ClickView and looking at certain metrics, and 2 examples here of mortality and length of stay. And I think Karen showed a picture like this. There's no greater motivator for performance than, you know, a reflection of how you're doing relative to your peers, as well as, you know, over time. So my personal opinion is that outcomes traced over time, historical comparisons of the same unit, for example, is a great sort of performance benchmarker. So we're doing this at VCOR. Hopefully it'll be successful. We'll roll it out to other cardiac registries within our school, depending on how successful that actually is. I won't repeat a lot of what has been said already, but there are huge developments in data, as people are aware of. I think automated collection of data is key. The extent to which data are collected as part of clinical care rather than as an aside. We started a particular service at St V's, again, going back a few years now when I was at St V's. We started a perioperative service and launched a database in parallel with the service. And the clinicians at the coalface actually used the database to help with their practice every day. There was a back end that married to the PAS system. So data was collected as they went along, and in fact, they needed the data set, you know, to undertake their everyday activities. Data linkage, I think Chris or maybe Gil has talked a lot about. We had a seminar not long ago at the school attended by representatives of the data linkage unit at the state. And it seems like the state has overcome a lot of the hurdles that were there before in terms of allowing for linkage. And we're not even talking about linkage within the data sets that might be held by the health department, but also perhaps by welfare, and certainly outside the state, you know, Commonwealth health data sets, etc. We have talked about patient-reported outcomes, and I won't repeat it, perhaps only to say that, and it reflects my bias as someone who's, as Chris said, interested in health economics, actually productivity of patients, the extent to which they can actually go back and contribute to the economy of the country. This obviously would apply to Yves patients with the Fontan patients, but certainly we are dealing with increasingly younger population as well. One exciting development is, in terms of data collection, is actually text mining. This is the analysis of unstructured text, and there is more unstructured texts that are generated than there are structured texts. So information that's written in letters, for example, or reports for radiology or pathology, etc. There are methods that use natural language processing, etc., to try and analyze these data. And I think we're going to open up quite a large avenue of research in that area. I've just come back from Singapore at a conference on outcomes research, and many of you probably have heard of this term before, or it's called real-world evidence. It's this kind of notion that the information that we use to change practice should be actually based on real world rather than in the largely artificial setting of the research environment. And if I could explain, if you indulge me just briefly for 2 minutes, we talk a lot about evidence-based practice. And if you think about it, we can deconstruct evidence, or rather cross-tabulate evidence, into this sort of matrix. 3 types represented by the columns, and 3 ways in which we use it represented by the rows. So efficacy, really, that drawn from studies, is really evidence that is, can it work? It's largely theoretical. Whereas effectiveness is actually, does it work, which is that it's been tested in the real world. And then importantly, especially for reimbursed markets, healthcare markets like ours, is it worthwhile? Is it cost effective? And most of the data from studies, clinical trials, is the archetypal study design, as you know, is drawn from data regarding efficacy. There are very few clinical trials that actually breach this middle column of effectiveness, and that might be the uncommon exception of the pragmatic trial, for example. And yet, despite this, we would systematically review these data, and then they inform clinical guidelines. This sort of red area, by and large, is not in the consciousness of a lot of clinicians, at least, and perhaps not policymakers as well. But real-world evidence is really the combination of data from research with real-world data on outcomes, natural history, etc., and then cost. And that last column, that last sort of data input obviously then puts it into this last column. And there is an emerging science called comparative effectiveness research, which is ideally what should be informing how we practice. It takes into consideration the data from trials and combines it with real-world data to make it applicable to the real life. And then the further combination of that data with cost and utility, quality of life data is the science of health technology assessment or cost effectiveness. We've talked a lot about sort of registries driving change. I think once you start talking about costs, no doubt it'll drive change even more. Karen might have mentioned registry-based trials. I think registries themselves not only providing real-life data, but the opportunity to undertake trials that are actually much more relevant than your typical trial. So these are just two editorials that were published recently about, and they were referring to registry-based trials. So the two great advantages are that these trials are going to be undertaken and the outcomes are actually collected as part of the registry. So it's a completely efficient strategy. And then secondly, and perhaps more importantly, is actually going to recruit a much more representative population because these are registry patients. So the relevance and applicability of these actual trials is much greater. So that's a great opportunity, and Chris is already undertaking at least one registry-based trial with ANZSCTS. And I think Yves mentioned the other strategy for comparative effectiveness research is this analysis of data, comparison of non-randomized data using various strategies like propensity score analysis. The last thing I want to say is that we should be looking at a broader engagement. I'm conscious of clinicians being here, academics and people from departments of health, or at least the State Department of Health, but I think healthcare is going to be in future not only the responsibility of the Department of Health, but Treasury and Finance. And Treasury always looks to the Department of Health as the kind of entity that reaches out its hand and asks for more and more money without actually producing any kind of benefits. I'm not sure if Treasury and Finance realise that healthcare is an investment rather than an expenditure. So the extent to which we can show benefits that go beyond health, productivity, cost, etc., through things like registries, I think that's important. And then the engagement of industry is also, I think, relevant. The PBAC, I serve on a couple of Commonwealth committees in terms of how they make decisions. And as you probably know, there's a lot of modelling that goes on, projection about whether or not a particular healthcare intervention is going to be cost effective. But beyond that, it actually doesn't make any further evaluation at all. So the truth is, we spend $10 billion on the PBS every year, for example, but we don't actually know what we're buying with that. We spend $150 billion in total for healthcare in a recurrent year, in a recurrent expenditure, and we really don't know what we're buying. And that's the kind of role registries, has a key part in playing, is actually exposing some of that information. And everyone should be involved, including industry. That's all I had to say. Chris, thanks very much.
Thanks, Danny. Any questions for Danny? It might just be an opportunity to lead straight into the next sort of phase, which for the last 15 minutes or so, which is a panel discussion. So I might ask our speakers, Jeff, John, Gil, Karen, Yves, and Angela to come and join us just at the front. And this is an opportunity now for questions, comments, anything that hasn't been covered that you'd like to draw out, to test our panel to see if hopefully we can provide some some opportunities for answers. So perhaps, look, while you're thinking of questions, I just might kick off. And I guess it's really around, I think Brett Forge made a comment that he was really surprised that some of these registries weren't mandated, and that he couldn't really believe that there wasn't a requirement from government to be able to report on outcomes for registries. I guess maybe I could start with Karen. Do you see sort of the mandating the registry activities, particularly in this area of high cost, high risk, high volume? Do you think we're getting to a point where this will be the avenue for funding in the future?
I mean, it would, in some ways, it would be good to see it, but I don't think that it is likely to happen in the near future. Actually, I think what's more likely to happen is that the data collected and the outcomes from registries, the health department, for example, will mandate that we need to report from that. So then they'll facilitate funding registries. But in terms of mandating that you have a registry, I don't think that's likely to happen in the near future. And I'm not sure whether it's necessarily the answer either. I know John has some stronger opinions on this, don't you, John, about mandating registries?
We've never operated on the basis that they are likely to be mandated. Rather, we've tried to put forward a value proposition which is so compelling, and that value proposition is firstly to clinicians, because they provide clinicians with extraordinarily valuable information that they want. It's a value proposition for administrators because it provides a little bit of accountability and transparency as what's happening in their hospital. And thirdly, to policymakers who want the data to help plan the future. So I've personally always felt that that value proposition is so strong that it doesn't need mandating.
Any other comments?
I think that there's no, and we have discussion very often, but there's no mandate to collect data for pediatric heart surgery. And when you look at how much it costs, everywhere in the world you have to report these results. So it's surprising that it's not done yet in Australia, and that's going to happen. So we're trying to, do it beforehand. It's so expensive that I cannot imagine that any government would spend that amount of money without having a look at what is being done.
Mm. Yep. Gil.
I think there needs to be a bit of a carrot and stick approach. Obviously, Prof O'Neill thinks carrots are the thing, but the stick will be involved in this public reporting area, because by implication, those who are not mentioned will be considered to be, for some reason, inferior. They just don't want to be participating, and that, I think, would be one of the most forceful determinants of participation. Once we start public reporting of units, then if unit XYZ is not there, the assumption will be they don't want their information known, therefore they're second rate, and that will make them join, I think.
Yes, Leanne. Danny, do you want to tackle that one first?
Sure, Leanne. Sure, Chris. Good question, Leanne. The personally controlled electronic health record promises a lot. I think the 3 people who signed up so far are very happy with it. But when it takes off, that'd be incredible, I think. Those sort of hospitals around town who have been fortunate enough to be quite far advanced in their EMRs know what the benefits are. Unfortunately, at the Royal Melbourne, Leanne, as you know, is a little bit at the other end. But I think the main thing is overcoming a governance issue, and with data security, whatever the latest ISO standard is, etc., we're going to overcome that. And it's great to see, there's a willingness or a will to do that. So once we get the will, we've got the technology's always been there. The will and the governance that is sorted out, it's just going to take off, I think. And maybe we've probably been saying that for a long time, but it does seem, as you sort of picking up, I think we are on the cusp of it.
Danny, you touched on the fact that the VAED, there seems to be a change in, or an increased awareness of the value of all this information there, and we haven't been using it perhaps as effectively as we may have been. Where do you see that, and how do you see that, sort of particularly with the focus on the cardiac registries in terms of improving outcomes?
Yeah, I mean, it'd be nice if Eileen or maybe Anna could comment on this from the state's perspective, but we attended we hosted a seminar rather at which the Victorian Data Linkage Unit was very well represented, gave a talk. Ying Chen gave that talk, and she spoke so positively about what the state wants to do about opening up all the data that it holds to linkage, including outside VAD, VMD data sets, and then the kind of window or portal to Commonwealth Health data sets as well, Chris. So the truth is, I guess, is that those of us long enough in this game have been waiting a long time for this to happen. But it, again, on Leanne's point, it does seem like it's sort of ducks being aligned, and maybe the Duckett report is going to be, a big stimulus for access to data as well.
Eileen and then Jim.
Just a second, Eileen.
I'm just thinking about health services and supporting clinicians and driving things from the top within health services as well, and the role of boards and all of your clinical registry data. So I've had the opportunity to sit on clinical governance committees and on the board of a small rural health service, and I can't for a minute imagine boards reading through a whole lot of annual reports for registries, and yet they're a very important bunch of people for clinicians to have an influence with, because they will probably support you with your funding. You have the KPIs or the data that they really need to see. So I just wondered if you had any thoughts around how we could get clinical registry data to the boards and administrators of hospitals, so that they would be engaged with it as well as the clinicians.
Jeff, maybe you'd like to tackle that one.
Actually, from our own experience, when we disseminated the information on our registries, we touched on some areas of sensitivity. There were some hospitals that were quite happy for their information to be disseminated not only to the principal investigator but also to the quality departments within various hospitals and to the CEO and to the executive sponsors. And other hospitals were much more sensitive to that. They didn't want their data necessarily spread out throughout the hospital. They wanted to be more in control of the data. So, your point's valid, but I guess what we found in our experience is that you have to take into the local landscape. Each hospital, each health service has a slightly different perspective on how the data need to be disseminated. So from our point of view, what we try to do, and this is one of the strengths of what we do, is that we are at a local level, and we can more or less say what each hospital, out of the 30 odd hospitals that are in our registry at the moment, we know more or less how each hospital wants their data to be disseminated. And so a number of those we would send stuff through to the CEO or through to various members of the board, and other not. So there's an element of that local issue. On a more general level, how it be done is challenging. I agree that the number of reports that come through are large, and the report, for example, our report is 60, 70 pages long now, so that's going to be too much for anyone to read. And that's a good point, and maybe we should, as an individual registry, should consider coming up with you know, an executive summary report or a brief report that might be relevant to people who are busy and not necessarily going to read all the details.
John.
Just adding to what Jeff said, I think the boards of hospitals, Elena, are one of the most powerful levers that we've got at the moment to enhance registries. And you know, I chair one of the Metropolitan Hospital Quality Committees, and we routinely ask people, you know, we get a report, say, each month from a renal unit or the cardiac unit or whatever. And in the past, I must say, they've been disappointing. They've told us about how many patients they've seen, how many registrars and all that sort of stuff. But increasingly, we just ask them, well, how do you compare with your peer hospitals? And that draws out the registry data. And I gave a talk to the chairs of all the quality committees a couple of months ago, and I think there was enormous interest in, they didn't know, a lot of them, that this information existed. And so that's one of the levers which we've got to improve the scope of registries without having to mandate anything, or, you know, it's just happening.
Jim, and
I wanted to just follow up on Leanne's point, but more to the direction of the hospital electronic medical record rather than the personal medical record. I think around the country there's a lot of activity going into the development and purchase of electronic medical records. I'm just wondering whether what the panel would think the best approach to being able to effectively unify these are, because it gets back to sort of data dictionaries, I think, and to be honest, it gets down to cost, because storage costs money, and the people paying for these systems often don't want to pay for the storage that every particular group thinks they would need. Perhaps adult cardiology departments, you know, in this room accepted, might not store information at Fontans or something like that. I personally think that's going to be a major issue in maximising the benefit that we've heard about today. I just wonder whether there's a way of getting in early and ensuring that we can actually amalgamate.
anyone like to take that one on? I think you're making a really an important point, and I guess that's going to be, I think, one of the challenges for the rollout of EMRs, and so we've got the opportunity to make sure that we can amalgamate and we can actually take the added value that they can provide. Yes, Ange, do you want to make?
I was just going to add something to that. We've said from the outset with VCOR that we would look to import data from existing systems where they meet the criteria for the registry, which is doable. That can be managed. We're currently now dealing with 3 different vendors with local systems, some of which capture all of the data because they've been built that way, that health services invested in that. Others that will capture some of the data at the point, and this is in the PCI space only, at the point of the PCI. The problem is within health services, there's a lack of interoperability of systems talking to each other, let alone the fact between health services, and how a registry is going to deal with that in terms of the cost implications to actually handle these, different methodologies, different database systems is, frankly, we're just going to start with the low-hanging fruit. The vendors that want to work for their clients in the health services and do some work at their end, and then we're going to do the work at our end, and we're going to hopefully start getting data in a less onerous fashion than what we've historically had with VCOR. But I can't wait to see it. But there's a lot of problems.
Make it an investment so they know they can optimise the benefit. I know governments don't put it that, but that's pretty key to me, I think. Rather than do the cheapest option up front, they need to do the one that will be beneficial to the
Sorry, my question was around the applicability of the methodology you're using for procedures and those sorts of registries to something that's more like the ACS or the heart failure population. And it seems at the moment that those sort of populations are more that snapshot methodology, including stroke does an audit every now and then. Is that where we should be looking towards for these sorts of things, or should we be aiming for something like a registry model for your heart failure, ACS, non-procedural type clinical care patients?
It's a good point, Harry. our experience again is that we have looked at heart failure, which falls more into a clinical grouping rather than a procedural grouping, and it's challenging because of the number of patients and the heterogeneity of all those different patients. They don't belong to one unit in one hospital, they belong to multiple units. So it becomes a logistics issue. And I know if Brett's still here, Brett would be right behind you on that topic and trying to get registries in clinical syndromes, in heart failure, in ACS, and that kind of thing. And in an ideal world it would be good, but I think that considering what the cost constraints are, what the human resources constraints are, that it'd be very difficult to mount a systematic and fully subscribed type of ACS registry. It's just too hard. There are thousands and thousands of patients, and so at the moment now our experience is that the snapshot type model is the next best thing, and I think that's what we're likely to see for the foreseeable future.
I think I may have more provocative views, but so right now, if you have any kind of condition, you go to your surgeon, and I may be wrong on that, but I think if you look at your performance, it's a bell curve. It's a normally distributed curve. So you have 50% a chance to be operated by a surgeon that is below the average of standard, because that's the distribution. And so I don't think that's normal. You want to have be operated by somebody who's average or is a little bit better than that. So the only tool we have right now to look at quality of care is the short-term outcomes. And apart from Bristol, where you had a 25% mortality for hospital mortality, well, you cannot demonstrate any difference in outcomes, because you're talking, in my field, you're talking about 1 to 4% at the highest difference in outcome. And so there's, you cannot discriminate or make much progress. If you look at coronary bypass surgery, I mean, what you need is not hospital mortality. What you need is an angiographic control of all the anastomosis you're doing. Then you're going to discriminate your surgeons. That's going to be interesting. I did a paper a few years ago on the long-term outcome of tetralogy of fallow repair. I was stunned to see how little comparison between centers, or even less so between surgeons, you have if you look at long-term outcome. Do you know that if you look at one of the paper is from urology. So if you have a prostate cancer, and if you do a PSA, not like me, but if you get your PSC tested, you have high chances to have your prostate removed. Well, your chance of having incompetence, peeing in your pants every day, varies between 0 and 20%. And so, and we all acting as if the quality of care was uniform throughout the care system. But I think it's a joke. And so the only solution is long-term, I think, is to have registries or some kind of monitoring of medium to long-term outcomes. And so we're aiming to do that in pediatric cardiac surgery in congenital heart disease, because we know that our short-term outcomes are among best in the world. You get a long-term outcome monitoring, then you really have best care in the world, I think.
Thanks, Yves. John, perhaps final comments.
Final one. I think there's been a lot of concern about some of the outcome measures that were too simplistic. You know, the death at 30 days, like, for example, in intensive care. Is that the purpose of intensive care? You know, and it's increasing effort to try and ask ourselves, what is the good outcome from this procedure? And say for prostate surgery, it might be complete removal of the cancer, plus no incontinence, no impotence, good quality of life. But they've got to be wound together. And those sophisticated outcomes, I think, are very much what the future of registries is going to involve.
Terrific. Thanks very much. Look, I'm very conscious of the time. I think we've had a terrific afternoon. We've heard a lot about what's happening in Victoria in relation to cardiac registries. It's an exciting time to be involved in this, and we've got a lot to look forward to in the future. I wish, could you join me in thanking the panel and thanking yourselves for participating this afternoon. Thank you.